Good evening, everyone. Tonight we have Dr. David Smith with us. He is an MIT-trained engineer who did his medical training at the University of Chicago. He has been a practicing physician for over 30 years. Dr. Smith is an orthopedic surgeon with Bone and Joint Physicians. They have multiple locations with offices in Oak Lawn, Orland Park, Flossmoor, and Calumet City. Tonight we are going to be answering questions that have been submitted about knee pain and treatment options. As we answer them, please feel free to submit your additional questions and we will go through them as they come in. Now we've had, it looks like, a couple of questions submitted, so without delay, I am a 65-year-old and the majority of my knee pain has been generating from knee injuries. Can knee pain create leg weakness?
Yeah, the answer is yes. I mean, a lot of people who develop arthritis will get a secondary weakness. It's called reflex inhibition, not to give it a fancy term, but it's just the leg tends to shut off the muscles because of the pain generated, and it's a sort of a defense mechanism. So atrophy or diminished muscle strength is part of arthritis.
From the same person, I have had multiple knee arthroscopic procedures on both knees and now have been told I have osteoarthritis. If I have knee replacement, will this help?
Well, let me expand on that a little bit. I think I get the gist of it. The person's had their knee scoped multiple times, and over the years, the arthritis has gotten to a point where I suppose the doctor may have suggested consideration of a knee replacement. And that is a standard, very accepted, very effective treatment for osteoarthritis. So the answer to that would be yes. But I think one thing you have to keep in mind, a lot of us over the age of 60, if you took 100 people, 60 and older, who swore that they didn't have any knee pain at all, and just said, well, let's get some x-rays. And a lot of those patients with no symptoms, over the age of 60, we would start to see some changes on the x-rays that would be termed arthritis. So you want to be certain that you don't let a diagnosis confuse you with the problem. The problem is your knee hurts. You just always want to keep it simple. If you've got a problem where the knee is inhibiting your ability to enjoy life and do things, whether it's sleeping or just being able to go bowling or go for a walk, then that's the problem, not the fact that you have an x-ray that shows arthritis. So I'd just like to distinguish those. But yes, to answer your question, knee replacement is a reasonable and very effective treatment for severe osteoarthritis.
Okay. And again, from the same person, I have difficulty getting up from low chairs or walking upstairs due to knee pain. Could this be addressed with knee replacement surgery?
Well, that's a good question, and let me answer it this way. I think there's a hierarchy of goals that we're going to try and accomplish with the knee replacement. And I think we want to start with the first goal, and that is so a person could stand and walk around, reasonable, age-appropriate activity levels. And that varies person to person. Depends on your general health, your general conditioning. Sometimes I think that we have expectations that can't sometimes be met for everyone. In other words, I have patients who come in and they're really having a great deal of difficulty walking at all or standing for even very brief periods of time. And so knee replacement is usually pretty effective at helping those people. However, going up and down stairs, getting out of a low chair, are stressful things for us in our 60s. So I wouldn't want to promote knee replacement as a solution for every ache and pain that we in our 60s are likely to have. Certainly, I think there are people that following the knee replacement, if they do their therapy and they're fortunate and things heal well, can do stairs more easily, can get out of low chairs more easily. But I think that's a little more the bonus activities. What I really look for the knee replacement is allow the person to walk and to stand and be comfortable at rest. Stressful activities, stair climbing, can still cause a little soreness or irritation.
Okay, another set of questions. I am a 50-year-old female with severe joint pain from extensive arthritis, bone on bone. First, I am interested in knowing more about your custom-made knee implant and whether or not there is a minimum age for it, and does it typically how long does it last in comparison with a non-custom-made joint?
Well, let me explain that a little bit, because I think people get confused, and certainly the big companies that make these prostheses will oftentimes advertise different features. So let's talk about custom-made versus the standard. Right now, the custom-made implants have not proven to be superior to the non-custom made. It's just like most of us go to the shoe store and we get shoes off the rack and we do quite well with them most of the time. You can find a size that fits. In the 30-some years that I've been doing knee replacements, the manufacturers have produced more sizes and range of sizes that we can accommodate most human anatomy. Some of the early experience, I haven't gone into doing the custom made, in other words, where they actually make a different prosthesis, in other words, out of metal and plastic for an individual. It just doesn't seem to have proven itself to a point that it's superior, in some ways even equal. The only experience I've had is a few surgeons I've known who have done it, and they've had an increased revision rate. So I can only say this, and I think certainly you can go online and explore these things. These have not been out long enough where there's enough literature to justify going to that step. And what I don't like about them is without a really good track record, if I was going to have a knee replacement, I would not want a, quote, custom made. I would want a proven design that the engineers had worked through the scaling of these sizes to something that we know from past experience has functioned well. It's sort of like if you went out to the airport and you're going to go on a flight, and you say, well, here's a plane, a DC-3, it's been around for 50, 60 years and got a good track record and it's well tuned up. Here's an experimental aircraft that doesn't have that many hours on it, and would you necessarily want to get in the experimental craft? And so sometimes it seems appealing, like having a custom-made suit or custom-made shoes. The problem is in the design of these features, there's no guarantee that that's going to give you a better result. And my concern is, from what I've seen, is I think it can give you an inferior result. But each person needs... What I want to say about answering these questions, we want to try and give you some general comments. It's also important to discuss things with your own doctor. That's really the person who knows you best, and they can tell you what they think is best for you, and we just want to give you some additional information.
Okay. What is the general length of stay for this type of surgery, and I mean knee replacement surgery, and what is the recovery like?
The average stay is 2 to 3 days after the operation. Now, more and more we're hearing about people go home the same day, and that's something that some folks are looking at. But I think in all the hospitals I've been at through the years, a 2 to 3 day stay is fairly typical, and I think there are some advantages to that. What's the recovery like? Well, that's often difficult to answer because it certainly varies person to person, but in general, I can tell you what I do for my patients, and that is after they leave the hospital, the vast majority of them, 90-some%, go home. they don't go to any type of extended care. I like to do that whenever possible. I think the more you can stay away from larger groups of people where there may be someone having wound problems, and if you're in an institution, you have that risk of picking up an acquired infection. So getting people home quickly from the hospital, I think, is good, and letting them return to their home environment if at all possible. I have patients use a walker or crutches for 4 weeks, even though many of them could walk without that. I just think it's a safety factor. You're doing something, you're making an investment for a lifetime. I think the safety of using some type of ambulatory aid is really critical, and I think that walkers are usually the safest things. A cane won't even hold itself up, so I'm not so sure it's going to hold you up. So 4 weeks with some type of walker or crutches. Then during that time I have people on blood thinners for 4 weeks and commonly use Coumadin. Physical therapy, the average is, I would say, 2 to 3 months of therapy. 6 weeks is an important landmark. A lot of patients are starting to return to some of their activities of daily life, more independence. But certainly at 12 weeks or 3 months, you're going to feel better than you did at 6 weeks. And at 6 months, you'll feel better than you did at 3 months. So it's a slow progression. And I tell patients, you'll often see improvement up to 6 to 12 months. So it is slow, but probably the most restrictive is that first 6 to 8 weeks when you're using the walker for the first 4 weeks.
Okay, I would like to review some videos of full joint replacement and partial knee replacement surgery. Can you recommend a good place to review videos?
Well, YouTube has lots and lots of videos of operations, total knee and partial knee replacement, and it's an excellent place, and they actually show the surgery itself, and sometimes the surgeons are talking to other doctors, and in some cases it's for a more general audience, but there's plenty of them. If you go on YouTube and just put in total knee replacement or partial knee replacement, you'll find plenty of videos to satisfy your interest in that area.
Okay, I sprained my right knee, and I was wondering why I'm getting the same pain in my left knee. Is this due to additional stress on my left knee?
Well, that's certainly reasonable to consider that. Again, as I said before, we don't want to be making diagnoses and recommending treatment online. It's just basically to tell you from my experience that I do often see people that have had injuries on one side of their body, particularly on the weight-bearing extremities, and they'll develop some compensatory changes. And I often explain it as saying if you had a labor crew and there were 4 guys normally and 2 of them go on vacation, then you put a lot more load on the guys that are remaining, and that's true of your joints. They've done studies where they look at what we call gait, or how you walk, and when you have an injured extremity, you'll spend less time bearing weight on that extremity, which means you're bearing more load on the opposite knee.
Okay. I recently injured my left knee, resulting in a torn meniscus root. What would be some of the treatment options?
Well, arthroscopy is probably the approach most doctors take nowadays to meniscal injuries, and that would be the approach I would recommend. It's usually outpatient surgery, usually crutches for 1 day, followed by physical therapy and restriction of activities that are appropriate to what the doctor saw at the time of the surgical treatment.
Okay. My x-ray shows bone spur or osteophyte. What are some of the options to get well?
Well, let me answer this way. A spur, or what we medical term osteophyte, what does that mean? To me, that's a sign of a problem. Now, occasionally the spur or the osteophyte can irritate the surrounding tissue and can cause some discomfort itself, but that's not that common. Most times it's not the fact that you have osteophytes or a spur, it's the fact that you have arthritis. The formation of this reactive bone occurs when the cartilage wears out in your knee. So the problem there is lack of cartilage. And much in the same way, if you were driving down the street and you saw a sign that said bridge out, you could get out of your car and take the sign down, but it wouldn't change the fact that the bridge is still out. So what that osteophyte is saying is the cartilage has been diminished. You're having abnormal forces on the knee. As to options for treatment for arthritis, I always talk about the 5 categories. There's pills, basically anti-inflammatories, Motrin, Advil, Aleve, one of the 100 different ones available. There's injections. Cortisone can be very effective. There's a thing called viscosupplementation, and these are gels that we inject to help with the lubrication of the joint. There's braces, everything from the simple elastic ones you get at the grocery store to more custom design ones that unload a portion of the knee. There's physical therapy, which is really an important part. A lot of people with arthritis have lost range of motion that needs to be restored. They're not going to be able to walk comfortably until they rebalance the knee. They need to strengthen it. Like one of our earlier questions was, can you get weakness with arthritis? And the answer is yes, but you can work to try and overcome that to some degree. So pills, shots, braces, physical therapy, and then finally surgery. Some patients can benefit from having an arthroscopic surgery on their knee, even with arthritis, if it's in that mild to moderate range. And individuals with more advanced, significant arthritis that have failed conservative treatment, in other words, they've tried the pills, the shots, the braces, the therapy, then knee replacement becomes an option, and there's a whole lot to consider there. We're going to have some live talks I give at our offices in Homewood Flossmoor as well as Calumet City coming up in the future here, so in which we're going to address some of the issues in having a knee replacement. What are some things you need to be aware of?
Okay. I have a clicking sound when I bend my knee. I'm told it's loose cartilage. What can be done about this?
Well, again, you want to really try and get to the heart of the problem. If I had a knee that made some sounds and didn't cause me any pain, I'm not so sure I'd do anything about it. And the fact that you were told it was loose cartilage, I assume was made, that diagnosis was made based on either x-rays or most likely an MRI. So you just want to be certain that the diagnosis has kind of been locked in. In other words, certainly if someone told the doctor that they had some clicking, the doctor might say, well, it could be loose cartilage. To really confirm that diagnosis, you'd want to get an MRI of the knee. What can be done about loose cartilage? The most common thing that's done is surgery, arthroscopy. Again, an outpatient surgical procedure. You have minimal number of sutures or stitches afterwards, usually 2 to 4. 2 small little areas where we go in and clean out the joint. So I think that would be the most likely treatment once that problem was identified.
Okay, would my primary care physician be the best person to administer a cortisone shot, or do I need to go to a specialist?
Well, I think, any doctor who feels comfortable giving the injection, which I think certainly your primary care physician would, in most cases, be the one who could give you the cortisone shot. Some internists or non-surgeons just don't do that because it's not part of their practice. And then you would go most commonly to an orthopedic surgeon for those injections, or a rheumatologist. So those would be the doctors who do most of the injections. But certainly there are a lot of excellent primary care physicians who do this all the time, and that's part of their training. So either one is fine.
Is Voltaren safe?
Well, I suppose that's a philosophical question, like saying, is driving a car safe? Voltaren is an anti-inflammatory, what's called an NSAID, non-steroidal anti-inflammatory drug. What that means in English is there's a group of medicines, the ones we all know about, get at the drugstore: aspirin, ibuprofen, Aleve, which is naproxen, work through some similar mechanisms to diminish inflammation in our bodies. All of them carry some risk. They can affect the anti-inflammatory. They can affect and cause inflammation in the intestine. They can produce ulcers. They can have effect on your kidneys, your liver. So the truth is, millions of people take these medications, but there are significant complications that occur. I've heard numbers up to 50, 60,000 people a year have serious side effects. And so it's something that certainly your primary care physician, your internist, even your orthopedic surgeon can give you some guidance on that. If you do take those medications on a long-term basis, you should monitor it. In other words, check kidney function, renal function, and make sure you're not having problems in your GI tract.
Okay, this looks like it's our last question, so if there's any additional ones, please feel free to type them in now. I have been getting anti-inflammatory shots in both knees for about 4 years. I have been told that in time the shots will not work anymore and that they will harm the bone. What are my treatment options after that?
Well, let me just tell you what I tell my patients, and that is, and I assume when you talk about anti-inflammatory shots, there's two types of shots. One is cortisone. That's the one I would call an anti-inflammatory shot for the most part. And the other is the gel injections. You'll hear various names. There's Supartz, Synvisc, Orthovisc, Halligan. But these are all similar in the sense that it's what's called hyaluronate, which is a chemical that's present in the natural joint fluid in your knee. Now, as patients with arthritis, it was found some years ago that arthritic joints were deficient in the lubricating fluid. They didn't have as much of that as was normal. So about 15 years ago, it was found that ways to isolate that chemical and then inject it back into knees. And I've been doing them for about 15 years, and it's very effective for a lot of patients, certainly not everybody. Now, the one comment you made about you've been getting anti-inflammatory shots and you've been told that the shots will not work anymore and they'll harm the bone. Well, that's a general statement that carries some facts, I suppose. I'm not so sure about harming the bone. Cortisone, if you were to take large doses of cortisone over a prolonged period of time, it certainly could accelerate the normal osteoporosis that a lot of us see with age. However, when I weigh risk versus benefit, I don't really put any artificial limitation on how long a person can benefit from the cortisone shots. In 30-some years of giving those shots, I don't think I've ever seen anyone where I really felt that the cortisone shots themselves resulted in any significant harm to the bone. More likely what I saw was a person whose primary problem was arthritis, and they happened to be getting cortisone shots. And during the years that they were being treated for the arthritis progressed. The cartilage wore off, and you put more and more pressure on the bone, and it started to erode into the bone. So you did see bone changes. I don't think necessarily that the bone changes were related to the injections. More so they were related to the fact that you had arthritis. I often compare it to watching these TV shows where there's been, let's say, a chase scene where someone's being pursued and they get a flat tire and they keep on driving. Most of us pull over, change the tire. But what happens if you just keep driving is pretty soon the tire falls off, the sparks start coming out, and you do more and more damage to that wheel. The same is true of arthritis. There comes a time when the cartilage is completely gone. One bone is just rubbing on the other, and it does start to damage the bone. So hopefully that answers your question.
We did get one final question. If you are overweight, and I realize losing weight is beneficial in all aspects, will this help relieve knee pain if you have been diagnosed with osteoarthritis?
Well, let me answer that in sort of general terms. That's something that a lot of us, myself included, do advise patients. However, I want to keep it in perspective. I've seen very skinny people with arthritis who have a lot of pain. So I don't think the total picture is that if you have severe arthritis and you lose weight, necessarily it's going to relieve all the problems. It probably does help in a lot of cases. Certainly if a person, let's say if a person's getting close to the point of having a knee replacement, well, it's doubly important then. One, you might be able to put it off for a while, and two, you certainly lessen the risk of getting an infection if your weight is more nearly normal. But I think the advice to lose weight or stay in a more normal weight category is just good general health practice, that in terms of all the other functions in our body, in terms of our heart and our lungs, you're better off maintaining a more healthy weight. And I think it can help the knees, so I would encourage it, but I wouldn't want to overpromise. I've seen people that have, at the extremes where they've had what's called bariatric surgery for weight loss, and they've lost dramatic amounts of weight, over 100 pounds. I've seen where it really helped those people. But ultimately, if the arthritis had already advanced over time, it still became a problem for them. So it's not the total answer, but I do think it's worth trying. As I've gotten older, I've noticed the scale doesn't work as well as it used to, and it seems like when I get on it in the morning, and somehow magically the numbers are getting higher. So I think we all have to struggle with it. As we age, we tend to put on a few pounds, and you do that every few years, and it can add up. So certainly try to maintain a healthy weight.
Okay, we'd like to thank you all for coming and submitting your questions. You can check out our website at boneandjointworld.com. There's all kinds of informational videos and audio podcasts. We do these webinars frequently, and as Dr. Smith mentioned, next month we'll be doing a couple of live seminars in our Homewood Flossmoor location as well as in our Calumet City office. Thank you very much.